Então, bom dia. Vamos dar início ao nosso Grand Round, então, aproveitando a oportunidade de ter mais um professor convidado de fora de Porto Alegre, que realmente é uma honra para nós. Então, eu vou passar para a professora Maria Inês Schmidt, que faça a apresentação do convidado e que tenhamos um bom encontro.
Bom dia a todos. Essa é a primeira atividade que o Projeto ELSA está oferecendo com o professor visitante em uma das linhas de pesquisa associada ao projeto. O tema de hoje eu considero muito importante. A demência é um problema de reconhecida, crescente importância internacional. E eu enxergando muitos de vocês aqui que provavelmente vão iniciar sua clínica daqui a alguns anos, vocês certamente vão encontrar isso de uma forma ainda mais importante devido ao crescente envelhecimento populacional. E é uma doença para a qual provavelmente nós já sabemos diagnosticar, mas tratar e prevenir e entender o que de fato está acontecendo, nós ainda estamos numa fase muito inicial de colocação das peças de um grande quebra-cabeça. Então, essa palestra que está sendo feita hoje é feita por um epidemiologista que vai tentar dar um olhar de onde nós estamos e o que é que a gente pode pensar em fazer. E como nós estamos iniciando a linha de base do projeto ELSA, para nós é muito importante fazer essa reflexão nesse momento. É com grande prazer que eu introduzo o professor Richey Sharrett, que além de um grande cientista, uma pessoa com quase 200 artigos publicados em literatura indexada internacional. Ele foi o coordenador dentro do NIH do estudo ARIC e também foi assistente de coordenação de vários outros estudos que você já deve ter ouvido falar. Pessoa muito experiente, professor da Johns Hopkins University e um cientista de grande capacidade e de grande aspecto assim humano, uma pessoa muito querida de nós e é um prazer muito grande tê-lo aqui hoje. Professor Richey Sharrett, please come here.
Thank you very much, Maria, and thank you for, I shouldn't say Maria, I'm supposed to say Maria Inez. And as an American, I always want to say Maria instead. Thank you very much for inviting me. This is a topic of great interest to me personally, as we're about to start on our project in Baltimore in looking at dementia in relationship to cardiovascular risk factors that were measured a long time ago. This way. Dementia is very common, starting with say 5 or 10% in persons at age 65 or 70 and going up to almost 50% in older ages. So this is a topic of great clinical importance. The prevalence is very similar in men and women. Some studies show it more prevalent in women. As defined in population-based studies, you want to make sure that the definition includes impairments in activities of daily living, that it's in persons who are normally able to function in a normal way. So we're not looking at people who are cognitively impaired at birth and remain cognitively impaired in old age, and impairments need to be in more than one domain. Clinically diagnosed, most Alzheimer's is clinically diagnosed as due to Alzheimer's disease, but I'll be talking about that in greater detail. Vascular dementia is diagnosed clinically much less often, and then there are other types that are not nearly as common related to Alzheimer's disease and rarer causes. As you can see from this, which was a U.S. national sample, that if you consider a milder cognitive impairment with some standard definitions, the prevalence is quite high in the younger people and adds to the overall burden. And the prevalence of Alzheimer's disease is far greater than the prevalence of clinically recognized vascular disease. This is of interest. Not only does the prevalence rise of either dementia or Alzheimer's disease rise about 20% with every year of age, but it's also curiously 9% less for every year of attained education. And there's a well-known association with apolipoprotein E4. So in asking the question as to whether dementia itself can be prevented or delayed, we first ask the question, can Alzheimer's disease specifically be prevented or delayed? Fortunately, we know a lot about Alzheimer's disease. We know the pathology quite well. The amyloid beta protein breaking off from a precursor protein and resulting in very distinctive pathological signs in the brain, these neurofibrillary tangles and neuritic plaques, which appear to be toxic and result in synaptic loss and loss of neurons. Corresponding to that is the fact that Alzheimer's cannot be diagnosed with certainty in the living patient. It really requires the pathologic demonstration. So any Alzheimer's diagnosed clinically is only probable Alzheimer's disease. The signs in the brain occur very early in life, and they spread through the brain, through brain substance in a predictable fashion. It's fascinating, and the persons who originally described that, the Brack and Brack, in 1999 described this, starting off with this transentorhinal stage in a very primitive area of the brain, spreading through the limbic regions, and finally to the neocortex, following the evolutionary development of the brain itself. And look at these prevalences. So this early stage rises with age and then falling off as you have more advanced stages. So that, look at this, 20% of, this is a very large autopsy sample, 20% of persons aged 25 to 30 years of age already having neurofibrillary tangles in their brain. And by the time you reach age 70, 95% of brains have evidence of Alzheimer's pathology. So can we modify the course of Alzheimer's? Well, there are 3 types of therapy that have been anticipated and tried, and lots of clinical trials. And the first method is some way of blocking the amyloid process itself, blocking the production of amyloid, its toxicity, trying to remove it, immunization against amyloid, and so on. Another approach is to try to protect the neurons from the toxic effects of the amyloid. And a third method is these newer methods trying to stem cell research to replace neurons or nerve growth factors and so on to restore neural tissue. However, and reviews are plentiful. Just look up Alzheimer's disease in the last 2 years and you'll see reviews. The reviews seem uniformly to say that we do not have at the present time any therapy which will really modify the course of Alzheimer's disease. Anticholinergic agents will modify its clinical findings to some extent, but as soon as the drug is withdrawn, the status of the patient is just what it would have been had they not been started on the agents. It doesn't modify the course. However, with many clinical trials underway, breakthroughs could happen at any time. So far, the anti-amyloid agents, which are the most promising, have been actually harmful, and have had, trials have had to be discontinued. I'm not going to be talking any more about Alzheimer's disease, just that on the horizon, something may happen. We're not there yet. Vascular dementia. Can vascular dementia be prevented? Well, vascular dementia, by definition, is a cerebrovascular disease. Stroke can be prevented. Stroke can really be prevented. Look at this. I like this old meta-analysis of trials, just trials of very short duration with very small effect on diastolic blood pressure, showing a 14% reduction in heart disease, but a 42% reduction in the occurrence of stroke. Stroke can very readily be prevented by antihypertensive treatment. Makes you think that vascular dementia could too. So what is the overall contribution of vascular disease to dementia? Well, as I said, the clinical evidence is inadequate. Just as you need pathological evidence to prove that Alzheimer's processes are involved in cognitive impairment, you also need pathological evidence to demonstrate that vascular processes are involved in the cognitive impairment. And unfortunately, and this is a review that makes this statement, there is no overall agreement about the pathology seen in the brain which can unequivocally be taken as evidence that the impairment in a person was due to blood vessel disease. Obviously, if someone has a stroke and after the stroke has a severe cognitive impairment, you can attribute that to a stroke. But dementia due to stroke is not common. It's the basis for the clinical diagnosis of vascular dementia, but it's not common. And it's unlikely that pathologists anytime soon will be able to look at a brain and say, these infarctions are unequivocal evidence of vascular dementia, because even a small stroke in a strategic location can cause dementia, and the locations haven't been well identified. Similarly, there are no agreed criteria for the microvascular, the small vessel disease, which can unequivocally be called the vascular basis for dementia, or the small infarcts that are related to the microvascular disease. So let me go back a bit. So what is needed is really pathology studies that are done on a proper epidemiological basis, that are population-based, where people have been assessed for their cognition in life. They have agreed to have their brains examined at death. And there are now a few studies like that with very interesting results. And this Rush Memory and Aging Project is a nice example, where they recruited people from retirement communities and from churches and so on, gave them a whole battery of cognitive function tests, and had donated brains to examine. Good follow-up. And at the time of the latest publication, they had 141 protocol cerebral exams. And this is what they found. It's a very interesting finding to me. In the 50 cases that had dementia, this is the proportion that had Alzheimer's disease. But look, in the 91 cases that were not demented, this is the proportion that had Alzheimer's disease. Pure Alzheimer's, meeting traditional Reagan criteria, pathology levels for a diagnosis of Alzheimer's dementia, were as common in those who were demented as in those who were not demented. The difference was that there's a very large group in the dementia group that had Alzheimer's and other disease, other pathology, which was more common in the demented group than the other group. Here's the proportion that had Alzheimer's, here's the proportion that had Parkinson's, and then in the non-demented group, there was about a quarter of them had no cerebral pathology at all. So mixed vascular and Alzheimer's pathology was the big. And among all the 80 cases which met traditional pathologic criteria for dementia, for Alzheimer's, most of the cases were mixed rather than pure. The Honolulu-Asia Aging Study went further than Rush, and I'm eagerly awaiting other studies that will have done the same things that the Honolulu study has done. They not only looked at large infarctions, which were found in 30% of the 285 brains, and lacunar infarcts, which are seen on MR imaging of the brain, which were found in a larger proportion. But they also looked for micro-infarcts, and this is what's new. It's very new. There are only a couple of places in the world that have appreciated the frequency and importance of these micro-infarcts. 400 microns in maximal diameter. You can't see them on gross pathology. They're very, very tiny. And they were found in 20% of the brains in 3 or more of these infarctions, in 1 or more of these 38 blocks of brain in that proportion. Interestingly enough, well, before I get into that, even small infarcts, the kind that can be seen on MR imaging, ranging from a few millimeters in maximum diameter to 20 millimeters in maximum diameter, the so-called lacunes, which cause lacunar infarcts, and much more frequently cause no obvious symptoms at all, are found in a high proportion of persons without symptoms. And these data are from a study that I've been associated with, showing the percent of people that have those lacunar infarcts, and then in another study that I've had only a limited association with, age 65 plus, the prevalence is quite high. So in the Honolulu Heart Study, they looked at large infarcts and lacunar infarcts and micro-infarcts. And what was really interesting in Honolulu is that when they divided up the brains into those which had negligible levels, intermediate levels, or high levels of micro-infarcts, there was a very, very strong association with the percent of those brains, those 285 brains that had dementia. And look how similar that is to negligible, intermediate, and high levels of Alzheimer's disease. And their conclusion was that micro-infarcts, these tiny little infarcts, not only were more important than any other vascular pathology in the brain for dementia, but were almost as important as Alzheimer's pathology itself. This slide shows that in persons that have neurofibrillary tangles or neuritic plaques, but not the other, the concurrence of vascular lesions was very strongly related to the proportion that had dementia. So, in summary, during my professional life, I've seen a paradigm shift in the thinking about vascular dementia. When I was in medical school, we thought of Alzheimer's disease as a rare and familial form of pre-senile dementia. It merited a small paragraph in our large pathology book. They knew about plaques and tangles, but had no idea how prevalent they were. Shortly after that, the demonstration of Alzheimer's pathology in so many brains led people to generally believe that Alzheimer's was the overwhelming contributor to dementia. And now these more population-based studies conclude that there's lots of Alzheimer's pathology in brains of people who are not cognitively impaired, that mixed pathology, both vascular and Alzheimer's, is at least as common as pure Alzheimer's or pure vascular disease, that microvascular disease, both lacunar infarcts and these microinfarcts, contribute much more to dementia than classical multi-infarct, clinically obvious stroke does, and that vascular disease contributes greatly to dementia in persons who have Alzheimer's disease. We can't quantify any of that yet, but we can certainly say vascular is more important than we thought. It almost comes back to where we were when I was in medical school, that dementia was, quote, hardening of the arteries. That's not quite the right term, because hardening of the arteries implies atherosclerosis, and I believe this microvascular disease is a different arteriolosclerosis, lipohyalinosis, what have you, but not a cholesterol disease. So I want to spend a minute on, and how are we doing, on randomized clinical trials, because this is the most direct evidence we have on the ability to prevent dementia. The randomized clinical trials do not look very promising. Cholesterol. Well, as I said, if vascular dementia is not atherosclerotic but microvascular, then we wouldn't expect cholesterol to be a very important contributor, and we wouldn't expect cholesterol lowering to make much difference, and it doesn't. Hormone replacement. The trials indicate that hormone replacement in women is not effective in preventing disease. B12 folic acid. It may help in someone who has elevated homocysteine. You certainly would give it if someone is B12 deficient, because that's a neurologically important, but otherwise B12 folic acid is not helpful. So the two areas where you might expect help is in close glucose control or blood pressure reduction, and I'll briefly talk about the trials in those areas. In a single issue in the New England Journal last year, there were reports from two very large trials of lowering the hemoglobin A1C to 6 or 6.5%. One was stopped early because of increased numbers of deaths, possibly due to the hypoglycemia. The other one was not. They showed some, mostly not significant results for their primary endpoint. One of them has no intervention results available yet, but we expect those results sometime. The other one showed no association with stroke, cognitive decline, or dementia. Not promising, still waiting. And I'll go through the blood pressure trials in a little more detail. You probably all know about the SHEP trial, which was the first to demonstrate that it's safe and effective to treat high blood pressure, high systolic blood pressure in elderly populations. They looked at persons older than 60 with very high blood pressure, followed them up for 4.5 years, had a good reduction in blood pressure, and they found, look, these are very few events of incident dementia, despite a large study with nearly 5-year follow-up. This was mostly reported as a non-significant finding, but perhaps we're interested in the fact that there was a modest decrease in dementia incidence. Another trial done in England at the same time with the same kind of a population, same follow-up, even a little bit better blood pressure response, did not measure incident dementia. but they had two tests that are specific for vascular dementia, namely executive function and verbal and a learning test, both of which involve the more anterior and deeper areas of the brain that are thought to be related to microvascular processes. And in this trial, the placebo group did slightly better than the treated groups. Then along came a very small study from Europe with an enormous evidence of effect, very small numbers, a 55% reduction in incident dementia. Why? It's the same population, same kind of population of short follow-up. Only 2 years were double-blind, and then when they proved that it prevented stroke, they had to discontinue the placebo. Why in the world did they have this great evidence of improvement? Type 1 error, perhaps? Just difference between populations that we don't know. Then came this progress trial, which eligibility was anyone who'd already had a stroke or a transient ischemic attack. There was no blood pressure requirement, so they treated people, they lowered blood pressure in everyone, regardless of whether they had hypertension or not. A small decline in incident dementia, a little bit greater decline in cognitive impairment. And the decline in dementia was only in the group that had a recurrent stroke, which was utterly unlike the previous studies where most of the decline was in people who had never had a stroke and didn't have one at the time that dementia was diagnosed. And the cognitive decline was primarily in those with incident stroke. Again, funny finding, not the same as in previous trials. Interestingly enough, the reduction was just as great in those who were normotensive as in those who were hypertensive. And there were small sub-studies with imaging that showed a suggestion that there were reductions in small lacunar strokes and reductions in white matter hyperintensities that are small ischemic changes in the brain. Another study, and you'll notice as we get to more up-to-date studies that they can't do the same trials they did earlier, because the question as to whether you should treat old people with high blood pressure has already been settled by the time of these studies. So this is in people that are even older, with blood pressures that are not quite so high, where the clinical equipoise was, shall we really treat these patients who are very old and whose blood pressure is not quite so high, or are we going to cause cognitive impairment by lowering the blood pressure in these people? Are we going to cause reduced perfusion in the brain? And in this study, actually, the active treatment had a few more incident dementias than the placebo, as seen here. But cognitive decline was a little bit less. Most of these studies are inconclusive. Again, MR imaging, which was suggestive. The p-values here refer to not the randomized groups, but to the non-randomized, normotensive non-participant in the trial. So there was the randomized groups. Have I lost my? The randomized groups did not differ significantly. And then finally, another trial in a very elderly population with modest levels of blood pressure, and hazard ratios are in the right direction, suggesting benefit. So there were two meta-analyses of these, each suggesting hazard ratios below 1, suggesting benefit, one of them significant and one of them not. But I like to, each one of them left out one of these trials for good reasons, but I like to look at all of them. And what I like to look at here is the comparison. Maybe I can. Oh, do you have a pointer? It's still working. Okay, thank you. What I'd like to look at here is the comparison of the benefit for stroke with the benefit for dementia. Each one of these trials, including those that had only 2 years of active treatment compared with placebo, but had to stop that randomization after 2 years because of demonstrated effectiveness, every one of these trials showed substantial benefit for stroke. And the benefit for dementia was less. Remember, the MRC didn't measure dementia, but looked at cognitive impairment. And a little brighter. Yep, a little brighter. Thank you. I'll use this for that. Thank you very much. So the median change for stroke was a hefty 29%. All of these trials, as I say, even if they only had a very short duration, reduced stroke by almost 30%, but they reduced dementia by 14% or cognitive decline by 13%, the median effect. So is that the answer? Well, perhaps it is. Why does it reduce dementia less than it reduces stroke? Well, much dementia is not vascular. You wouldn't expect it to reduce Alzheimer's much. So this may be all you're going to get out of blood pressure treatment in persons who are older than 60 or who have already had a stroke. I don't think we're going to get much more out of the trials because you can't do the trials anymore. People know that you have to treat high blood pressure in the elderly. They're not going to randomize anybody to placebo. So it's difficult to mount new trials. And we're forced to go to the observational data to gather any more evidence. And I want to return to this slide that shows the 9% reduction in the prevalence of dementia for every additional year of completed education. I'm fascinated with that fact, and I wonder if it's due to biased ascertainment. Are we simply diagnosing dementia in poorly educated people more than we're diagnosing a person with good education? Well, the cognitive tests that we use are biased by education. Someone can do better remembering words if they're better educated and so on. But the diagnosis of dementia, though based on screening by cognitive testing, is validated by physicians reviewing the evidence, interviewing the informant about questions. Can he button his shirt? Can he wash himself? Can he get dressed in the morning? Can he do this and that? And I think that dementia is a pretty hard endpoint, and that this is not probably based on biased ascertainment, this relationship of better education with lower prevalence of dementia. So what in the world is it? And this is a study that though it's, let me see, what is the date on it? 2005. This is a study that most recently reported in 2005, but has interested me since its first reports came out years earlier. A Nun Study of sisters of Notre Dame from 2 cities in the United States, very old, who wrote autobiographies when they entered the convent at age 18 to 32. Their autobiographies, their handwritten autobiographies, were evaluated blindly for idea density. They had a very clear and specific and objective way of classifying these autobiographies as either being complex, simple sentence structure or simple sentence structure. Of course, it was done blindly without any knowledge of what the final status of the nuns was. And then 58 to 68 years later, they had 180 of these women who had had cognitive testing, and 90 of them had donated their brains. And in those who are cognitively intact, 18% had low idea density when they were young people entering the convent. But in those who were demented, the proportion was here. These odds ratios are enormous and highly statistically significant, and all levels of cognitive impairment in between fit on this curve. Those who wrote simple sentences when they were 20 years old became demented 60 years later. Not only that, their brains didn't weigh as much. They had less Alzheimer's disease. They had more Alzheimer's disease in their brain, particularly in the neocortex, these neurofibrillary tangles. So, what causes that? So first we think about possible errors. Was the exposure misclassified? Did they make errors in judging low idea density? Well, it was objective, it was prospective, it was blinded. I don't think exposure misclassification is a possible explanation for it. What about misclassification of the dementia? As I say, when you go through the entire algorithm of defining dementia, you can pretty well tell who it is who can't feed himself and can't button his shirt. I don't think it's due to misclassification of dementia. This is an interesting thing which we call in epidemiology, we call confounding. Did those women who wrote simple sentences when they were 20 years old somehow live a life that with environmental factors that damaged their brains? Was there an association between low idea density and getting their heads knocked around, to put it in simple terms? Well, all of the sisters lived in the same houses, they ate from the same kitchen, they had similar occupations, most of them were teachers, had access to the same medical care, they did not smoke or drink excessively. It's pretty hard to argue that those with simple sentences at age 20 knocked around their brains or damaged their brains. So we're stuck with two real reasons for that association. One of them is this fascinating concept of cognitive reserve. Cognitive reserve means those who are able to think in more complex ways, perhaps encode information differently, they retrieve information differently, they organize things differently in their brains. They have perhaps more synaptic connections in their brains. They have cognitive reserve. So if they get plaques and tangles over here, they've still got this part working, this part working. Their brain has lots of reserve and it can still function despite the pathology, cognitive reserve. Perhaps that's related to continuing to be physicians well into your later years, being active, doing crossword puzzles, teaching children. All the things that we do perhaps can maintain that cognitive reserve. Perhaps we can prevent dementia by maintaining cognitive reserve. Just an idea, hard to prove. The other one, the frightening possibility, is that the reason that the low idea density predicted dementia so many years later is that neuropathologic changes were already operating in these 20-year-old sisters. The Alzheimer's that they already had in their brains at age 20 just irrevocably, irresistibly led to more and more pathology. We don't know. I just leave that as a thought experiment, and we're going to go back to perhaps more solid ground again. What's the relationship between vascular risk factors and dementia? And a review of the literature reveals that the risk factors that are related, that are known to be related to dementia, are also those that are known to be related to stroke. Not surprisingly, both are cerebrovascular diseases. So diabetes, smoking, and hypertension, and these are some of the reviews. Now, very clearly for blood pressure, we see this relationship, that the blood pressure measured in midlife many years before the dementia, those associations are strong. But if you look at the more common studies of risk factors and dementia, those done in older people, those associations are weak, they're inconsistent. The relationship may be curvilinear, inverse, flat, or in the predicted direction. The associations of blood pressure in old people to dementia in old people are not consistent. Why? People who get demented become thin, their blood pressure goes down, they have poor diet, and the associations disappear. This, however, is based on scanty data. When we wrote a large grant to do the study we plan to do, and here's the study that we plan to do in ARIC, there were only 12 studies that had measured blood pressure and other risk factors in midlife, and then measured cognitive function in older life. And if we get going, we will be lucky enough to have the largest study of dementia with risk factors measured when people were 45 to 64 years of age, and we also have markers of both macro and microvascular disease to look at. By the way, the ELSA study is in the same position, and years to come may be able to do the same kind of study. And in these 12 studies, we have very strong associations between blood pressure in midlife and dementia later on. In 5 of them, it was known to be independent of stroke, and in 4 of them, the association was strong, but they didn't measure interim stroke, so they don't know, and there was only 1 with a null association. Diabetes remains related to dementia even when it's assessed in old age, not surprisingly, because if you're a diabetic, you're known to be a diabetic no matter what your age is. But when diabetes is assessed in old age, those who have had their diabetes for a long time are more likely to be demented than those who had it for a short time. And for smoking, diabetes and glucose. For smoking, we see this very nice association in a review that one of our colleagues did, where the relative risk depends on the age at which the smoking was assessed. This negative association may be because people give up smoking when they become cognitively impaired, but the nice relationship here again suggests that smoking at a young age is most damaging. Did I go the wrong direction? Oh, yes. Interestingly enough, there's also a number of reviewers believe that vascular risk factors are associated with Alzheimer's disease as well as vascular disease. Now, why is that? And there's 3 possibilities. One of them is that the Alzheimer's disease is misdiagnosed. It's really vascular disease. As you know, you have to have pathological evidence to prove it. So a relationship between blood pressure and clinically diagnosed Alzheimer's disease may be false. The other is that the relationship between blood pressure and Alzheimer's disease is because the vascular disease contributes to the dementia associated with a given level of Alzheimer's pathology. And the third is that perhaps blood vessels and ischemia actually contribute to the amyloid beta disease. And there is some, though scant, evidence that that's so. Neurofibrillary tangles in the cortex were not influenced by diabetes. They were strongly influenced by ApoB, but they were even higher if the person with ApoE4 also was diabetic. And the number of tangles in the hippocampus or cortex was greater in persons with very high levels of blood pressure than others. So Alzheimer's may have some contribution from vascular ischemia. So, in summary, can we prevent or delay the onset of dementia? We don't know yet for true Alzheimer's disease, but stay tuned. The clinical trials are coming out every month, and I wouldn't be surprised. With the knowledge that they have of the pathology and the specific therapies that are anticipated, I wouldn't be surprised if there weren't a breakthrough. The vascular dementia surely is preventable in theory, and the blood pressure trials suggest that even if you start blood pressure treatment late in life, you may get a modest reduction in dementia. Perhaps glucose will work, but it doesn't look so, and we don't have any clear evidence of benefit for anti-inflammatory agents or all sorts of other therapies that have been tried. So the soft evidence. Which interpretation are we going to make of the Education Association? Does it mean that young persons already have their fate sealed by early pathology? Or does it suggest that if we use our brains, we will not lose our brains? We just don't know that. And the observational studies, I think, are very promising in that they suggest that all of these brain vascular risk factors, blood pressure, smoking, and glucose control, all of them are strongly associated when they're measured in middle age. So how do we do anything about that? Are we going to put people on statins for 50 years? Are we going to lower their hemoglobin A1C to ideal levels for 50 years? Or are population strategies necessary in order to achieve a maximum benefit in old age? The burden of dementia is immense, obviously, and something, if we had an effective way of reducing it or delaying its onset, it would be worth considering. But we probably will need some kind of a population strategy, and I'm not sure that we can identify high-risk persons at a young age. I'll leave you with one more little thought experiment here. When I first discussed this topic a year ago at Hopkins, this study came out as a newspaper article, and in preparation for talking to you, I looked up to see if it had been published, and it had. So Netherlands investigators thought what they had was the oldest woman in the world. She, at age 80, had gone to the University of Groningen and asked them if they would be interested in her body for science. When she was 111, she went back to them and said, "Are you still interested in my body for science?" And they were. They did extensive cognitive testing on her, and they said she tested at the level of a 70 or 75-year-old person at age 112 when they last checked her out. And then when they examined her brains, it was almost totally clean from both the vascular and the Alzheimer's standpoint. So we are not all doomed to dementia, and your interpretation of this is as good as mine. Thank you very much.
Embora a razão principal da vinda do professor Richey a Porto Alegre tenha sido para nos ajudar a finalizar os últimos passos no controle de qualidade do projeto, vocês podem perceber pela palestra dele o quanto fez bem em termos de desenvolver entusiasmo no grupo, para a gente começar a pensar um pouco de ciência dentro desse projeto, cuja linha de base deve se encerrar mais ou menos em setembro do próximo ano. Eu acho que nós temos 5 minutos ainda para algumas questões que ele terá o maior prazer em responder.
Any questions?
Dr. Sharrett, thank you very much for your wonderful speech. As a matter of fact, I'm a little bit concerned about the sentences that I did wrote at the age of 20s. Huh? I'm going to look back to my homework at school. But the question is another approach. What you're thinking, your thought about the symptomatic management that are proposed nowadays for people with Alzheimer's disease, with the parasympathic drugs and so on. This is a gold way for the pharmaceutical industry to sell a lot of drugs. What are your thoughts about this, the efficacy of this approach?
Yeah, it's a very important question, and I'm no expert in that area at all. I mean, I understand, and the reviewers that I've read, and I cannot speak from personal experience, but the reviewers I read talk about benefits, symptomatic benefits and so on, but they seem to say that once the cholinergic esterase inhibitors are removed, that the patient is exactly where they would be if they'd never been given that. But nevertheless, if to the extent they give symptomatic relief, they make a person happier, more able to communicate with their family and so on, and probably should be used. But the family needs to know that they have limited effectiveness. Is that your impression as well? And there may be several in the audience who can speak to that much better than I.
Good morning, Dr.
Morning.
Sharrett. It was a pleasure to hear your brilliant speak. And I have two questions. One is related to the diagnosis of Alzheimer's disease. When we focus specifically to the neuropathology of the diagnosis, and it's the focus of definite diagnosis, and we still live in a kind of medical environment when physicians believe a lot on two assumptions. One, elderly patients who complain a lot of memory problems are in fact demented patients, demented individual. And the other assumption is the more neuroimaging alterations, the higher the probability of Alzheimer's disease. So this, together with the idea of the real diagnosis based on neuropathology, so our clinical job is flanked. So is
uncertain.
So
yeah.
Can you speak a little bit about the reliability of the clinical diagnosis of the probable Alzheimer's disease? This is the first question. The second question is...
Can I address that one before you get to the first one? Because I might not remember it.
Okay.
And then I'll let you take... So as far as the clinical diagnosis is concerned, I think things are getting better. They're beginning to distinguish the early stages, the mild cognitive impairment, as being either mnemonic type or non-mnemonic type, with the memory impairment being the one that's more likely to lead to real Alzheimer's disease. And as you say, with more and more imaging, you're better able to rule out vascular causes. I think where people really fell down in the past is that vascular dementia, that Alzheimer's was simply a diagnosis of exclusion. If they hadn't had a stroke history, it was Alzheimer's, and that was wrong. But now that you can look for lacunes in the brain and do much better imaging, and the imaging is getting very good now, and with careful cognitive testing where it seems to be more memory related and less executive function, verbal fluency and so on, it does tilt it towards a better diagnosis. So your next question?
Is about the Hashinsky's concept of the vascular cognitive impairment instead of vascular dementia.
I'm sorry, I didn't...
The vascular cognitive impairment
yes.
of Hashinsky, then vascular dementia.
Yeah, I was very sloppy about my language, and there is more interest in talking about vascular cognitive impairment, which I think is a much better term. Is that what you're referring to? Yeah, and I mean, you can talk about vascular cognitive impairment in a person who has lots of Alzheimer's in their brain. It refers to the contribution of the cognitive impairment from vascular causes. And I think vascular cognitive impairment just recognizes the quantitative nature of the vascular burden and its effect on the brain. But I'm not sure I answered your question. Did I? Okay.
Thank you very much for your presentation here, Dr. Sharrett. Thank you very much for your presentation. I would like to make two comments also. This was exactly the field of my PhD thesis. But I'm especially interested about vascular factors on Alzheimer's disease.
Yes.
And you mentioned it, but
right.
you focused more on vascular dementia itself. Especially microvascular disease has been associated with Alzheimer's disease more than would be expected by chance, implying that there might be a relation between two, not just associated with decreased cognitive reserve by lacunes and small brain infarcts. So like Binswanger disease, small vessel vascular dementia, Binswanger disease and Alzheimer's disease, for example, pathology have been associated. And one possibility, as you mentioned there, is that it might be in vitro and in vivo models also that ischemia triggers APP, amyloid precursor protein, because APP, alpha APP is neurotrophic. Instead, the amyloidogenic cascade is, as the name says, amyloidogenic, and if there is an imbalance between the neurotrophic and neurotoxic cascades, it might be that this reaction, just as in heart failure with adrenaline and the sympathetic system, might be that the reaction, the overreaction, might be worsened than better. So it might be that APP superproduction might be just a tentative of the brain to keep on with the memory functions. So there is an interesting paper that showed that people with mild cognitive impairment in reality produce more APP than normal controls, and especially in case of vascular mild cognitive impairment. And the second comment I was going to make is that as you mentioned that Alzheimer's pathology is universal. But I was going to make this comment, but I was going to mention exactly the same report you mentioned, that I would say is almost nearly universal, but with Braak stages 1 and 2, might be 3, but pathological break stage since 4, that is the actual, the nowadays criteria for Alzheimer's disease, from 4, 5, or 6. So is polemical, I know, but to differentiate normal aging from Alzheimer's disease, I think that is very current hot topic. What do you think about the differentiation between Alzheimer's disease and normal aging? I think this is very important.
Between Alzheimer's and what?
Alzheimer's disease and normal brain aging. Yeah. Like to differentiate physiological brain aging from Alzheimer's disease, I think that is very important field of research.
Yeah, I agree with all your comments. And I think there's a lot of animal research that indicates that the vascular may actually contribute to something of the metabolism of amyloid beta. And I'm no expert on that, but I find it intriguing. Is that what your work was on? Was it an animal
Yes,
base?
yes, exactly.
Yeah, very good stuff and promising. And of course, if vascular is related to the basic Alzheimer's process, it's very fortunate, isn't it? Because we can control these risk factors.
I did mention to you that of all the groups that we had, including this National Institute of Science and Technology that is dealing also with this issue. So I think we probably will have the next year several seminars, with many groups, each one contributing with their own aspects and their own disciplines to this very important issue. So I think because of the interest of time, we're going to have to close now, and I thank you very much for coming. And Richey, thank you very much for being here with us.
Thank you so much.